Hello. Very nice to see you all. First, I'd like to thank the organizers of the conference and Horsung So for the invitation to give this keynote. It's a great privilege to talk to you all about my research. And for today's talk, I'm going to talk about unleashing new promising approaches to promote physical activity in physically inactive adults. And I'm based at the Driven Center, which is a Danish Center for Motivation and Behavior Science, which we've established in the last couple of years. And if you want to read more about that center, you can scan the QR code. To tell you a little bit about myself, I've had a very international career so far. I was born in Denmark, and then I did my higher education, including my PhD in the UK. I did my PhD at the University of Bristol. And after which I worked in different universities across the UK, the longest period of which was at the University of Birmingham, where I worked from 2006 to 2014. In 2014, my family and I, so my husband and two young daughters, we moved to Perth in Western Australia, where we lived and we worked at Curtin University for 7 years. And we've now been in Denmark for the past 2 years after I've been away from Denmark for 25 years. It has really been a great privilege to work internationally because I've acquired a large network of collaborators who I really enjoy working with. Today I'm going to talk about two programs of physical activity behavior change research that I've been involved in. But first, I think it's important to acknowledge that physical activity is a highly complex behavior which is difficult to change and is influenced by a lot of different factors. And this overview by Adrian Bowman captures quite well how physical activity behavior is shaped by both individual, social, environmental, policy, and global factors. My research mainly focuses on the individual and social factors, but that doesn't mean that I do not acknowledge that the behavior is also shaped by the broader environment and policy factors. And many people actually would like to be more physically active, but physical activity is often promoted in ways that are not very conducive to sustained behavior change. So I provided two examples here on the left-hand side of the slide. The top one says, what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? So that's a very pressurizing way of communication, even when health professionals might have the best of intentions. But we can change the way people think about physical activity so they see the inner value in physical activity. And we know that when they see the inner value, it will be much easier for them to keep engaging in the behavior. So it's really no wonder that so many people are looking for quick fixes, given that we try to motivate others to exercise or be physically active in the wrong ways. So we need to study the latest evidence in psychology about effective ways of motivating others for sustained behavior change. And first of all, we talk about motivation, what drives behavior. Then it's important that we distinguish between the quantity or how much and the quality of motivation. So the photo on the right here illustrates a high level of motivation. It's a high quantity, but the quality is very low because given the chance, the man in the photo wouldn't run. So individuals can hold multiple types of motivation to different degrees. Um, and we can look at the self-determination continuum to understand that a bit better. So the highest quality motivation is represented by high self-determination. So intrinsic motivation at the top means that the person is physically active because they enjoy it or find it pleasurable. However, high self-determination can also include doing an activity because it aligns with the person's values or is part of their identity, or because they value the benefits of doing the activity. And in contrast, low self-determined motivation, which is also called control motivation, or which is of low quality, is characterized either by external pressures, such as a doctor or family member pressurizing the individual to engage in the behavior and maybe punishing or rewarding them if they do or don't do the behavior, or due to internal pressures, such as to avoid feelings of guilt or shame, to look good to others or get approval, and what we also call ego involvement. And finally, of course, a person can lack motivation altogether, which is called amotivation. So according to self-determination theory proposed by Deasy and Ryan, people in positions of authority, such as doctors or other health professionals, teachers, parents, bosses, can communicate in ways that can help promote either self-determined or controlled motivation. And they do that by either supporting or not supporting the three psychological needs, which are the need for autonomy, which refers to the need for a feeling of ownership, that you're the origin of your own behavior, not pressurized to do the behavior, but do it out of your free will. The need for competence, the need to feel that you can master challenges and engage effectively in the behavior, and relatedness, which refers to the psychological need to feel meaningfully related with others in a particular context. And so the satisfaction of these three psychological needs will result in self-determined motivation, whereas if the needs are not supported, non-self-determined motivation will follow. So finally, self-determined motivation will result in positive behavioral, cognitive, and affective consequences. So in terms of behavioral, that could be, for example, adherence and maintenance to physical activity. The cognitive could be learning, better learning or attention. And the affective and emotional consequences could be things such as feeling better as a result of being physically active. And of course, the opposite will be true for non-self-determined motivation. So according to self-determination theory, these three psychological needs are what we're trying to change. So they're the targets for interventions. And it's important here to also note that they're considered universal, that they transcend all cultures. They're not always consciously valued, but we also have these needs from birth. So what is the evidence that these theoretical principles play out as expected? In 2021, we conducted a meta-analysis or published a meta-analysis where we examined if self-determination theory-based interventions, where you compare an intervention based on self-determination theory principles to a condition which do not receive these principles, whether they lead to changes in need satisfaction, self-determined motivation, and related health outcomes. And we included 73 intervention studies that included a range of health behaviors, which included physical activity, healthy eating, smoking cessation, alcohol abstinence, medication adherence, and dental hygiene. And the results showed strong support for the use of self-determination theory-based interventions, as it found that it tended to result in changes in self-determined motivation, changes in health behavior, and maintain change in the health behavior over time. So when we design interventions, we're trying to avoid the Itlakiati principle. Does anyone know what that stands for? It stands for, it seemed like a good idea at the time. If interventions are not based on theory, we have no way of knowing why interventions do or do not work. And that's why it's so important that we use theory to guide intervention development. And there have been several efforts to identify how the social environment can communicate in ways that satisfy the needs and foster this development of self-determined motivation. And the diagram here illustrates a series of things the social environment, such as health professionals, for example, can do to support the individual's experience of autonomy, competence, and relatedness. The feeling of autonomy can be supported in different ways, for example, by providing options, offering clear choices, supporting the individual's own initiative and encourage them to explore the behavior, avoiding the use of external rewards, because external rewards is a controlled motivational strategy that actually increases dropout, and also use autonomy supportive language, using terminology such as could, choose, instead of things like should and must. And the health professional or others interacting with a person can also support the sense of coherence and relatedness by respecting the person's realities, perspectives, and values, actively listening to them, and identifying what options are available to obtain support in the behavior change process. And finally, the experience of competence can be supported, for example, by other people helping the person to identify what gets in the way of change, to set clear, realistic, but also challenging goals, and providing constructive, specific, and meaningful feedback so they help them feel that they can master the challenges. And these principles have actually had an impact on practice. So the American Heart Association actually promotes similar principles. They encourage heart surgeons and other health professionals in contact with heart disease patients to adopt what they call the 5 A's approach: assessing, advising, agreeing, assisting, and arranging, which actually aligns with very closely to the principles I showed you on the previous slide. Based on the overall strategies I presented before, in our research group in Australia, we developed this program, a communication training program, which we have offered in a variety of programs with community and clinical groups. And these strategies include both face-to-face and online workshops to train people in positions of authority or with expertise to communicate in ways that support the psychological needs. And we've also used mobile applications, self-reflection diaries, illustrated video clips, among other things. And we've applied this approach in the workplace with physically inactive employees and in retirement homes with physically inactive older adults. So this leads me to the first promising approach, the use of peer leaders as part of complex interventions designed to promote physical activity in physically inactive adults. So why peer leaders? Well, because peer leaders are credible messengers, as they are similar to the participants themselves and are therefore relatable. They've often been through similar experiences and can perhaps more readily empathize with the struggles of participants. They can act as sources of efficacy via modeling and verbal persuasion. And finally, and importantly, they could make interventions more sustainable because they are not paid, and they could engage in cascade training whereby peer leaders train new and upcoming peer leaders in a sustainable way. So with funding from the Cancer Council, Western Australia, and the Department of Health in Western Australia, we set out to examine the feasibility and preliminary efficacy of this peer-led motivationally embellished format across different workplaces in the Perth metropolitan area. We recruited 97 physically inactive office workers. 82.5% were female. They were aged 21 to 66 with a mean age of 44.4. And they were from 8 different organizations in the metropolitan area for Perth. And the organization included a mix of government departments, emergency services, hospitals, mining, and private corporate businesses. And one inclusion criteria was that they spent at least 50% of their time sitting. Most participants described themselves as Australian or European, and they worked in a range of jobs, including managerial and administrative jobs, professionals, associate professionals, and clerical workers. And on average, the participants were in the overweight category with a mean BMI of 29.2 at baseline. In regards to the study design, we implemented a cluster randomized controlled trial with work sites serving as the clusters, and the intervention was 16 weeks long. The control group participants were simply provided with a pedometer, a Fitbit Zip, and they were asked to accumulate a daily total of 7,500 steps. And we figured this is quite similar to usual treatment, as many target participants already have access to some sort of tracking device. We also asked the control group to wear research-grade Actipel monitors at the start to assess steps, sitting, and standing, which was then assessed again at the end of the intervention. We also asked them to complete a range of questionnaires to assess relevant outcomes. The participants in enhanced treatment or experimental group were assigned a peer leader who was trained in provision of need support and were asked to take part in 2 peer-led and 1 self-organized walk per week from weeks 1 to 6, with group-based walks phased out so that from weeks 7 to 10, they were asked to only take part in 1 group-based walks and 3 self-organized walks, and from weeks 11 to 16, they were requested to do 5 self-organized walks. And additionally, the participants in this group had personalized step goals and were asked to build up to 7,500 steps per day, depending on their baseline. And importantly, these participants also had access to an app, a mobile app, but I will come back to that shortly, and a walker training manual, which included tips regarding various aspects of behavior change. And they completed the same measures as the control participants. The peer leaders were trained via 2 face-to-face workshops. And in addition to receiving information about how to coordinate the walks, they received training on how to provide psychological need support to their participants. And that was done with a view to foster high quality, in other words, self-determined motivation in their participants, and therefore to empower the walkers, the new walkers, to change and sustain their new behavior. As mentioned previously, the participants in the experimental condition also had access to a custom-built smartphone app, which was developed specifically for this project, and the app served to support both the walkers and the peer leaders. And in contrast to commercially available apps, this mobile app consisted of 17 behavior change techniques that have been proven to be associated with physical activity behavior change. And we also ensured that the behavior change techniques were communicated in need-supported ways. So what did the results show? Well, we found that dropout was fairly low, and the acceptability of the various parts of the intervention, both in terms of the actual intervention and the training, was pretty good. With regards to behavioral outcomes, we did not find a significant interaction effect, although the enhanced treatment or experimental group did increase their walking quite a lot more than the control group. So you can see on the slide that the experimental or enhanced treatment group increased their step count by 509 steps per day, whereas the control group only increased their steps by 111 per day. The fact that there was no significant interaction is probably explained by power, as this was a feasibility, a pilot trial, which is not powered to detect significant differences, and also quite a high baseline step count in both groups. And we think the reason why the baseline count was so high is because we had to assess at baseline their steps, providing them with trackers, which might have caused some reactivity effects in the participants. In terms of sitting, and this is in hours per day, we didn't find a significant effect, but it was marginal with a small to moderate effect size for the enhanced treatment condition and a very small effect for the control group. And as you can see in the graph, sitting was decreased by 30 minutes per day in the enhanced treatment group and actually increased by 5 minutes per day in the control group. However, we did find a significant interaction effect for waist circumference, which was measured by the researchers, with reductions in the enhanced treatment condition and increases in the control group. So the reductions were about 1.5 centimeters, and the increases in the control group were about 2.58 centimeters. So this was a pilot randomized control trial, and as I said, it wasn't powered to detect significant differences, but we did have some promising findings. It was feasible, first of all, which is a very good promises were well for future interventions. We had low dropout, high acceptability. There were some small effects when we looked at the effect sizes for movement-related outcomes. There were higher baseline step counts despite screening for physical activity at the start. So we did ensure they were physically inactive, but their baseline score showed something different, probably due to the fact that the participants reacted in a way of making them more physically active as a result of getting the trackers for the baseline measure. We saw quite a large effect on self-determined motivation, but not only in the experimental group, also in the control group, which could also explain why there weren't more differences between the groups. And in the experimental group, we did see this 30-minute reduction in sitting, and other research has actually shown that 30 minutes reduction in sitting is clinically meaningful. So that's very promising. So we used a similar intervention format to train peer leaders in a retirement village context. And we were fortunate to be awarded money by the Western Australian Health Promotion Foundation to conduct this trial. And the primary aim of the project was to examine the feasibility of a motivationally embellished, which was informed by self-determination theory, group peer-led walking intervention, and to conduct a process evaluation to find out what worked and didn't work so well. So in this project, we targeted physically inactive older adults who were 60 years and older, who lived in retirement villages, and the intervention was 16 weeks long. So we wanted to develop and evaluate a 16-week peer-led, group-based, motivationally embellished walking intervention targeted to physically inactive older adults in retirement villages. In terms of the structure of the program, like in the START trial I presented before, we used this phased approach with a larger number of peer-led group walks at the start, which was then increasingly replaced by self-organized walks as participants developed self-regulation skills, and to reduce the dependency on the peer leader, therefore making it more sustainable. And we trained both the peer leaders and the walkers. In terms of the walkers, we trained them via workshops and educational material presented in a folder on the topics listed on the slide, and which are aligned with what we know from the literature are effective behavior change techniques. We also trained the peer leaders, and here we call them ambassadors in the project because the participants preferred this terminology. And they received 2 workshops, one before they started the group walks. And here, apart from educating them about the logistics of organizing group walks and safety features, we also taught them principles of how to provide need support, which we in our application refer to as strategies that could be used to support what we call the 3 Cs, which stands for confident, connected, and in control, which reflect the 3 psychological needs according to self-determination theory. And we used some published LAST principles that our research group has developed to educate peer leaders on how to communicate with their walkers to support their needs. And LAST stands for listening, advising, relating, and structuring. They received some goals, the peer leaders, in terms of what they should focus on each week in the program, and examples include helping walkers feel at ease at the start of the 10-week program in week 1, to helping walkers feel successful in week 3, to discussing changes walkers noticed as a result of their participation in week 8, to setting new goals in week 10. The second workshop took place 2 weeks into the group walks, so we could discuss with them how they went about implementing the strategies and talk to them about how to solve any problems they had encountered. For the trial, we recruited 116 walkers who were physically inactive and 8 peer leaders. And we really wanted to recruit more peer leaders, but it was really difficult as not many residents were willing or felt they had the time to serve on that role. And we recruited participants from 14 villages in different parts of Perth metropolitan area and also some regional areas. And for the study, we examined trial feasibility with regard to the randomization process and acceptability related to the evaluation. And we also employed the REAIM framework, which is a very well-known evaluation framework, which assesses reach, efficacy, adoption, implementation, and maintenance issues. For the purpose of this talk, I'm just going to talk to you about the evaluation in relation to efficacy. So as we found that a small number of walkers officially dropped out, which was encouraging, and we didn't see any adverse effects, which was a relief. While there were no group differences in physical activity and sedentary behavior, we did overall observe an increase in step counts of 750 steps per day, and also a reduction in sitting of 32 minutes per day. And that gave us some confidence that we were doing something right. In terms of the qualitative evidence, we found that the pedometers seemed to be a great hit with many participants. Some participants dropped their groups and started walking more on their own. Others stated that being part of the project had made them more conscious of how to build more walking into their everyday life. In some, there were a range of successes associated with the project, which included everyone liking the training, and those who started tended to keep it up, and overall participation led to favorable changes in both walking and sitting. Indeed, as I mentioned earlier, there is some evidence suggesting that reductions of 30 minutes or more of sitting per day can be clinically meaningful. In terms of future directions, we learned that it's incredibly important to engage participants in designing the recruitment methods, and we really had to learn as we went along. And we need to consider how we can reduce the perceived burden of research assessments, because participants really think of these as just more paperwork. And facilitating relatedness among the participants and facilitating social support was really critical, but the group format was not liked by everyone. So we may need to also consider one-on-one peer support for some individuals in this particular group. And some work done by previous PhD student of mine, Marlene Kritz, who focused on peer leaders in a physical activity context among older adults. She did some great work looking at what is actually an effective peer leader for older adults. And the aims of this particular study was to, one, identify overall what are effective peer leader attributes perceived by different stakeholders, and secondly, to explore perceptions of effective leadership attributes as a function of current levels of physical activity and also leadership experience. And we used a mixed methods concurrent triangulation design using a range of quantitative and primarily qualitative methods. And participants were 101 older adults, where 68 of them were interviewed. The participants consisted of 4 groups, and they were experienced walkers who had been walking for a while, inexperienced walkers, people expressing an interest in starting to walk more but hadn't started yet, inexperienced peer leaders who expressed an interest in becoming peer leaders but hadn't started, and then experienced peer leaders who had been acting as peer leaders for a while. And we used inductive thematic analysis to identify peer leader attributes and presented them as word clouds. And that allowed us to visually compare attributes that were more or less pertinent for the different groups. And overall, we identified 3 themes. The first was motivating, and that included being sociable, encouraging, and entertaining. Likeable was the second one, which referred to being inclusive, sensitive, and caring. And the third was credible, which meant being competent, adaptable, and dependable. And as you can see in the figure, however, there are important differences between the groups. So both inexperienced peer leaders and inexperienced walkers emphasize the importance of being encouraging, entertaining, and adaptable, whereas experienced peer leaders and walkers emphasize inclusivity as a particularly important attribute. So to answer the question, what is an effective walk peer leader for older adults? The answer is it at least partly depends who you ask. So importantly, several of the attributes we identified are not included in existing peer leader questionnaires, and that included things like caring, encouraging, inclusive, and it's not included in existing leadership literature. And those include the entertaining and adaptable components. So we can use this knowledge from this study to prepare a suitable and comprehensive peer leader questionnaire. The results can also be used to select individuals with appropriate attributes for peer leader roles to ensure that programs are as effective as wanted. And as many of the attributes are malleable or changeable, we can use this knowledge to train new peer leaders, and we can help organizers select appropriate peer leaders as well. And finally, the results could be used to help support new peer leaders to develop key attributes. Now I'd like to talk to you about the second new promising approach to promote physical activity in physically inactive adults. And this is a program of work I have done in close collaboration with my colleague, Professor Manos Damatakis at the University of Sydney, and other colleagues in Australia, the UK, and other places. So this is a project funded by the main Medical Research Council in Australia, called the National Health and Medical Research Centre. And we developed a new approach to promoting physical activity, which we have called vigorous intermittent lifestyle physical activity, or VILPA for short. And VILPA refers to brief, intense bouts of physical activity done as part of everyday tasks. And these bouts typically last 1 to 2 minutes each. And VILPA activities can include walking faster as part of the individual's daily commute, playing actively with children, taking the stairs instead of the lift, or cleaning with more vigorous effort. And the rationale for proposing this type of activity as a promising approach for physical activity promotion is that it's more likely to appeal to physically inactive individuals who have a dislike of structured exercise, or who do not feel they have the time, or are not confident, or otherwise perceive other barriers to structured physical activity. So we believe that this is a more scalable form of physical activity. As part of this project, we examined associations between wearable device-measured VILPA and mortality in over 25,000 people in the UK who had provided data to the UK Biobank. And they were followed for 6.9 years, and mortality records were then retrieved. And the results were quite striking. As you can see in the graph, there was a substantial reduced risk of mortality from any cause by doing just 3 to 4 VILPA bouts per day, each bout lasting 1 to 2 minutes. In fact, the risk of all-cause mortality was reduced by up to 40%, and so was the risk of cancer-related mortality, and the risk of cardiovascular-related mortality was reduced by as much as up to 49%. So these reduced levels of risk were similar to the effects of structured exercise for a comparable group of exercises. Because it's such a new concept, no VILPA interventions have yet been conducted. So in order to develop an intervention, it's important to first examine what are the barriers and enablers of VILPA in the target population. And this can help identify suitable intervention targets to use VILPA as a means of promoting health and well-being in physically inactive adults. In this study, we used 78 physically inactive adults aged 35 to 75, and most were women. Most perceive themselves to have good or very good health. At the same time, 82% consider themselves overweight. And for the purpose of the study, we conducted some focus group, and participants were divided into age group for the purpose of the focus group. So age groups: one age group 35 to 44, second age group 45 to 59, and the final group 60 to 76. And we did inductive thematic analysis, but we also used a COM-B model, which emphasizes and specifies determinants of behavior in relation to physical and psychological capability, physical and social opportunity, and reflective and automatic motivation. And the identification of capability, opportunity, and motivation beliefs can then be used to generate a behavioral diagnosis. In our inductive thematic analysis, we also used a critical realist approach, which combines ontological realism and interpretivist epistemology. And on this slide, you can identify, according to the COM-B, what were perceived to be barriers and enablers. So in terms of the barriers, we identified 6 of them. That included physical limitations, perceptions of aging, need for knowledge, environmental constraints, perceptions of effort and energy, and fear. And we identified 10 enablers, and these included convenience, reframing physical activity, use of prompts and reminders, normalization of taking the active option, gamification, sense of achievement, health improvements, personally salient rewards, identity fit, and changing from slow to fast thinking. And it was very interesting that most themes were actually consistent across the 3 age groups, except perceptions of aging, which was not evident in the youngest group, and gamification was not identified in the oldest group. And the fact that they were quite similar across age groups, these barriers and enablers, suggest that Wilper interventions targeting middle-aged and older adults may require limited customization, which actually speaks to the potential for these interventions to be delivered at scale. So finally, I'd like to propose some lessons learned and some future directions. In terms of the first approach I talked about, the first promising approach on peer leaders, we know from research that peer leaders can be powerful promoters of physical activity, but it's also important that they have the appropriate attributes and they need to be trained appropriately to support high quality motivation in their participants. So not everyone is an equally effective peer leader. And we shouldn't underestimate also the challenges associated with peer-led interventions, both in terms of time, in terms of recruitment, that can be very difficult to recruit, and also in terms of training. Can we train them? How well can we train them? And the second promising approach referred to vigorous intermittent lifestyle physical activity, which is a new promising approach to increase physical activity in individuals who are not willing or who are unable to engage in structured physical activity. And one of the big benefits of Wilper is that it addresses many of the barriers of structured physical activity that have been found in previous literature. And in terms of the future, we need to design interventions that promote Wilper among different population groups, and these should really address beliefs related to capability, opportunity, and motivation, as I showed in the previous study. What are some future research directions in these areas? The first one would be that it would be important to identify the most effective ways of actually implementing motivationally supportive peer leader training into routine practice. And here we need to work with stakeholders, organizations that work with peer leader models, ensuring that these are evidence-based, and how can we best ensure that the evidence base that we have can be implemented into these large programs that can be delivered at scale. It's also important to examine the effects of peer leader attributes, both on the motivation and retention of peer leaders themselves, but also on the long-term adherence, maintenance, and well-being of participants who are interacting with these peer leaders. It would also be important to see how technology could support or enhance peer leadership training. It may even be useful to explore how artificial intelligence can be used here. In terms of Wilper, it will be important to test the feasibility and also effects of Wilper interventions that really address the barriers and enablers that we identified in the previous study, which can lead us to develop a behavioral diagnosis that can then inform the design of these interventions. And finally, it will be important to examine ways that mHealth and digital technology can be used to actually promote Wilper in different population groups. Now, I'd like to thank you all for your attention, and I hope you enjoy the rest of the conference. Thank you.